Hello everyone. Today we are going to discuss one of the complications of chronic kidney disease. So in today's session and in next 2-3 sessions we will be discussing the complications in CKD patients. So there are many complications seen in CKD patient. Most important and most common is anemia. So today we are going to discuss anemia in CKD patients, various guidelines to treat anemia and what are the causes of anemia in CKD patients. In next lectures we will be discussing renal bone disease, fluid and electrolyte disturbances in case of CKD patients. So today our topic of discussion is anemia in CKD patients. So there are many reasons for anemia in CKD patients. In in most of the CKD patients, those who are on dialysis, the hemoglobin eventually falls below 8 milligram per deciliter. So we have to take measures to improve the hemoglobin level in CKD patients so as to prevent symptoms and complications related to anemia. So what are the various causes of anemia in CKD patients? So one of the most important causes, failure of erythropoietin production by diseased kidney. As we all know that erythropoietin is very essential for erythropoiesis. So failure of erythropoietin production by diseased kidney is one of the most important cause of anemia in CKD patient. There are many other causes also which contribute to anemia in CKD patients, like reduction in red cell survival. Severe hyperparathyroidism also suppresses bone marrow. Nutritional deficiencies are also seen in CKD patients. Most of the CKD patients on dialysis are malnourished. They are deficient in vitamin B12, folate. Iron deficiency is most commonly seen in patients with CKD. So in CKD patients, there also chances of bleeding is very high because of platelet fragility or decreased red cell survival. So there can be occult GI bleed in case of CKD patients, which can also contribute to anemia. And also infection and inflammation, because they are having decreased immunity in CKD patient, they are prone to infections. So these are the main causes of anemia in CKD patient. Most important is failure of erythropoietin production by diseased kidneys. Now, how to diagnose and evaluate anemia in CKD patients? So first of all, diagnosis of anemia. In adults and children more than 15 years of age, anemia is considered when hemoglobin is less than 13 gram per deciliter in males and less than 12 gram per deciliter in females. So what are the various investigations we routinely do in a patient of CKD? So most important is complete blood counts, including RBC indices, MCV, MCH, MCSC, to diagnose whether the anemia is normocytic, microcytic or macrocytic. Retic count is very important to diagnose whether there is a marrow is hypo or hyperproliferative. If marrow is hyperproliferative, to look for reasons of hyperproliferative marrow, to look for blood loss or to investigate for blood loss. If there is significant fall in hemoglobin, then go for colonoscopy or endoscopy and further investigations for anemia. Iron indices are very important: serum ferritin, serum transferrin saturation, and for nutritional deficiencies, of course, vitamin B12 and folate levels. So these are the basic investigations we should do in a patient of CKD to evaluate for anemia. So after evaluating the cause of anemia, we will go to treatment part. So how to treat a patient, how to treat anemia in a patient of CKD? First, we have to look for the causes. So we all know that erythropoietin production is decreased in CKD patients. Apart from erythropoietin production, we should look for iron, vitamin B12 and folate. Before starting erythropoietin stimulating agents, we have to correct the iron deficiency, vitamin B12 deficiency. We have to treat any underlying infection or inflammation condition before starting erythropoietin stimulating agents or erythropoietic agents. Otherwise their effect will not be uh, full-fledged if we start directly the erythropoietin stimulating agent. So iron therapy is very important in patients of CKD. For adult CKD patients with anemia who are not on iron or ESA therapy, IV iron therapy is advised before starting ESA treatment. So before starting erythropoietin agents, we should correct the iron deficiency. If transferrin saturation is less than 30% and ferritin is less than 500 nanogram per ml, so we should give the patient iron therapy before starting erythropoietin. So when to evaluate the iron stores? Every 3 monthly we have to evaluate iron stores during ESA therapies, because in CKD patients there can be occult blood loss, malabsorption. So all these conditions contribute to deficiency of iron in CKD patients. So we have to evaluate for iron therapy every 3 monthly during ESA therapy. So avoid administrating IV iron to patients with active systemic infection. So in case of infection, we should avoid giving iron therapy in CKD patients as well as in normal patients. Avoid giving iron therapy to patients. So this is all about iron therapy. If T-set or transferrin saturation is less than 30% and ferritin is less than 500 nanogram per ml, so first correct iron deficiency before giving erythropoietin. So next is erythropoietin stimulating agents or erythropoietin agents. So before initiating erythropoietin therapy, as we have already discussed, address all the correctable causes of anemia prior to initiation of ESA therapy. So what is the advantages? What is the advantage of giving ESA therapy? It reduces the blood transfusions and anemia related symptoms in CKD patients. But we have to individualize the therapy in every patient, whether the patient is on dialysis or not, based on that, whether patient is having any active infection or active malignancy or not. So we have to individualize the therapy based upon status of the patient. So use of erythropoietin should be used cautiously in patients with active malignancy or who have history of stroke. In some studies, it has found that there is increased mortality in patients with active malignancy or end stage malignancy and in patients who had history of stroke. So when we have to start erythropoietin therapy or at what hemoglobin erythropoietin therapy is recommended, there is no clear-cut guidelines which suggest that at this hemoglobin erythropoietin therapy is suggested. But according to latest KDIGO guidelines, in patient with hemoglobin more than 10 gram per deciliter, ESA therapy is not recommended usually. For adult CKD patients not on hemodialysis, non-dialytic patients with hemoglobin less than 10, ESA therapy should be individualized based upon patient to patient. And for adult patients with CKD stage 5 on dialysis, ESA therapy should be used to prevent hemoglobin concentration below 9. Then how to maintain the ESA therapy? So ESA therapy is not to be used to maintain hemoglobin above 11.5 milligram per deciliter. We have to use ESA therapy to prevent it to fall below 9, and we should also have a target to maintain the hemoglobin less than 11.5. So dose should be individualized based upon patient's hemoglobin, body weight and clinical circumstances. Re-evaluate ESA dose in case of any adverse effect or in case of any acute or progressive illness and inflammatory condition patient is having, to adjust the dose accordingly. So what are the various options available to us in case of erythropoietin stimulating agents and how to administer them, whether we have to give them IV or subcutaneous? So in case of CKD patients on dialysis, IV or subcutaneous administration is preferred, but in case of CKD non-dialytic patients, subcutaneous administration is preferred. So what are the options available? We have epoetin alpha and darbepoetin alpha. So darbepoetin alpha is slightly longer acting. It has to give 0.7 to 0.75 microgram per kg body weight once every 2 weekly, and the poetin alpha we have to give thrice weekly at a dose of 20 to 50 units per kg. So this is all about erythropoietin therapy. So we should individualize the erythropoietin therapy according to the patient's condition, whether patient is on dialysis or not, according to the uh, body weight of the patient and any infection or inflammatory conditions. We have to watch the ESA therapy carefully, and in case of stroke or in patients with active malignancy, the ESA therapy should be used cautiously. So how to monitor the therapy? At initiation of therapy, monitor the hemoglobin monthly, and at maintenance dose in CKD non-dialytic patients, monitor hemoglobin every 3 monthly, and in CKD patients who are on dialysis, monitor hemoglobin on monthly basis. So when we call ESA hyporesponsiveness, if hemoglobin concentration is not increasing despite of starting adequate dose of ESA treatment, so when we will call it as ESA hyporesponsiveness if there is no increase in hemoglobin concentration from baseline after the first month of ESA treatment on appropriate weight based dosing. You have started the ESA according to appropriate weight of the patient, but there is no hemoglobin improvement, so then we call it as ESA hyporesponsiveness. So in patients with ESA hyporesponsiveness, avoid repeated escalations in ESA dose beyond double the initial weight based dosing. Try to look for the causes of ESA hyporesponsiveness. One of the most important causes of ESA hyporesponsiveness is iron deficiency. If we have directly started the ESA therapy without correcting iron, so it is the most important cause of ESA hyporesponsiveness. So other causes, active infection. Look, there can be any underlying inflammatory conditions. Look for elevated C-reactive protein for underlying infection or inflammatory conditions. Also check the adherence level, whether the patient is adherent to or compliant to the dose prescribed. Then look for elevated red tick count. In case of there is hyperproliferative manure, look for blood loss or hemolysis. Order endoscopy or colonoscopy according to the status of the patients. So these are the causes why ESA hyporesponsiveness can be seen in patients of CKD. So try to evaluate the patient for ESA hyporesponsiveness, correct the nutritional deficiencies. Vitamin B12, folate, iron are commonly patients are deficient in these nutrients. So treat the underlying infection or inflammatory conditions, and also check for adherence. So this is all for today. If you like my video, please like, share and subscribe my YouTube.